say that heart disease is our #1 killer of women, and 1 in 3 women will die from heart disease. So this means that 1 woman every minute will die from heart disease. So it's important as women we take the ability and we take care of ourselves and we look to screen and keep our cardiac wellness, to keep ourselves functioning, because we are the glue to our family and we are the glue that holds this community together. So when we think about heart disease or heart attack, we often think about that left arm pain or the crushing chest pain, but it's not so in women. It's silent in women. We get all sorts of symptoms that are not truly recognized in the community and by us. So it's important to be educated and understand what heart disease means and what that means to us and how we stay well. So I just want to take a moment and introduce, we are doing a kickoff for Women's Heart Health Program. So what this program is a screening for $25, and we will do a heart risk assessment, blood pressure checks, BMI, weight management screenings, non-invasive tests to check for cardiovascular disease in the legs, as well as personal wellness coaching sessions and educational resources. We'll be offering this, our kickoff is on February 16th at 5 o'clock in Barrel Oaks Winery. So please, we're giving away for screenings for this event as well. So take a moment. The other thing that we're doing is we're doing cardiac scores. So cardiac wellness scores for the month of February, which is recommended for women age 55 to 75, and then 45 to 75 to identify any risks for heart failure or heart disease that may be hiding inside of them. So, any questions or concerns, please let me know. Thank you very much.
There's some pretty scary statistics. All right, our event sponsor for today is Sentara Northern Virginia Medical Center, and Michele, is it Eckhardt?
Good afternoon. It's my pleasure to be here. I want to recognize members of our team that are here today. First and foremost, the president of Sentara Northern Virginia Medical Center, Kathy Johnson. Please stand. Sandra Connor, who's the director for Radiology and Imaging Services, joined by Melissa Vitello, also from Radiology and Imaging. Yvonne Barber, who leads our Mammovan initiative. And Drs. Aisha Arshad, who is with the Sentara Heart and Vascular Center, an electrophysiologist, and Dr. Tammy Lamb, who's a women's imaging specialist with Sentara Radiology Specialists. And last but not least, I would like to recognize Susie Lee from the Potomac Health Foundation. Potomac Health Foundation has been pivotal in providing funding for many programs in our community, including the Sentara Mammovan. Thank you all for being here with us today. My name is Michele Eckhardt, and I'm in the Office of Physician and Community Relations at Sentara Northern Virginia Medical Center. Sentara Healthcare, a leading healthcare system, came to Prince William County in late 2009. Building on the foundation of the local community hospital, Sentara Northern Virginia Medical Center has continued to grow and expand services to meet the growing population in our community, including the opening of the Sentara Heart and Vascular Center in May of 2011, which offers diagnostic cardiac testing, vascular procedures, cardiac device implants, and 24-hour-a-day response for patients experiencing cardiac emergency. This month, we launch our Women's Heart Center designed to address the specific needs of women. The opening of Sentara Lake Ridge, our ambulatory emergency room located near the intersection of Minnieville and Old Bridge Roads, offering 24-hour emergency services supported by emergency medicine trained providers, full scope radiology and imaging, and laboratory services. Implementation of Sentara eCare, electronic medical record, which supports real-time documentation, improved communication and coordination, and enhanced quality of care and patient safety. We have expanded access for radiology and imaging services by opening sites of care. Our Sentara Comprehensive Breast Center offers diagnostic capabilities, including 3D mammography. Our Sentara mobile mammography van is also now equipped with 3D. We have dedicated women mammographers, nurse navigator, fellowship-trained surgical oncologist, radiation oncology services, and ZOF, which is intraoperative radiation therapy. In early 2016, we opened the new Sentara Surgical Services, a state-of-the-art surgery center, which also gives a whole new face to Sentara Northern Virginia Medical Center along Opitz Boulevard. We have recently expanded the services of the Sentara Heart and Vascular Center with the opening of an electrophysiology lab, with future plans for an additional cardiac catheterization lab. We introduced HIPAA-compliant MARTI technology, My Accessible Real-Time Trusted Interpreter, providing real-time access to medical interpreters in more than 250 languages to support the diverse communication needs of the community we serve. We've continued outreach to the uninsured and underserved in our community through the Family Health Connection mobile clinic providing primary medical homes, collaboration with the Prince William Area Free Clinic and the Greater Prince William Community Health Center, and our OB clinic, which provides access to quality prenatal care for uninsured moms. Sentara remains committed to improve health every day. We are business leaders, students, wives, mothers, grandmothers, and friends with many responsibilities and obligations. Paramount to our ability to live up to these responsibilities and obligations is the foundation of good health. It is Sentara's distinct pleasure to partner with Prince William Chamber to host today's Healthy Women, Healthy Community Women's Luncheon. Thank you.
And again, thank you for hosting the event today. I believe, is the person going to come up right now? She's going to try to fix. Can you hear me in the back? Okay, at this time I'm going to introduce our panel. When I call your name, if you could join me at the front of the room. Oh, I'm sorry, I just we're all set up over here. So as I introduce, if you could please come up and join us. Our panel today from Novant Health UVA Health Systems, Dr. JoAnne Gutliph. She's a gynecologist with Prince William OBGYN. From Sentara Northern Virginia Medical Center, Dr. Aisha Arshad, who is a cardiologist and has a lot of other initials after her name. She'll tell us more of what her specialty is, cardiology. From Novant Health UVA Health Systems, we have Karen O'Brien, Dr. Karen O'Brien. She's the Senior Director for Behavioral Health Sciences. She's looking at me like I'm crazy. Yeah, sign me up.
Not yet.
And from Sentara Northern Virginia Medical Center, we have Dr. Tammy Lamb, who is, she told me she specializes in women's health. Each panel member will have 10 minutes to present, and then at the conclusion of their presentation, with time permitting, we will ask questions and answers if time allows. So at this time, we will start off with from Novant. If you guys don't mind, can I just say Novant and Sentara? I know, because I think we all know the full names, but anyway, we have Dr. JoAnne Gutliph, who is, am I saying that right, gynecologist? Because it doesn't look like it's spelled that way. Right? Gynecologist, okay. All right.
So I guess I'm going to stand up. Red is the color. I guess that's what turned out that way. And I have Clicker of an OBGYN for 30 years, 25 years in Prince William County and the Manassas area. Over the years, traditionally, women came once a year for their annual exam, which included a pap smear. And you've probably noticed over the last 5 or more years, it's been a little bit confusing because your doctor may have told you, oh, well, actually, you don't need to do a pap smear this year. And I think there's been a lot of concern and worry, why am I not getting my pap smear? And we probably have not done a very good job of explaining to you why you're not getting your pap smear this year. First of all, and it's not because we don't think pap smears aren't important. They have done a tremendous job at reducing the risk of cervical cancer. cervical cancer is a very preventable disease, and so we do think that doing a pap smear is a very, very important test that we still want you to have done. This is just the information about this, and 10 minutes, so I'm going to be sort of moving things along here kind of fast. This is over the years how we have been able to decrease the rate of cervical cancer, and certainly we can do better by doing pap smears at the appropriate intervals. Now, a lot of my patients are concerned and think that somehow the government is taking away their pap smears as a cost-saving things, and honestly, that's not the truth. The truth is that a lot of medical societies, the American Cancer Society, the American College of GYN, National Preventive Task Force have done a lot of research on the appropriate intervals for pap smears to try to make sure we're doing them at the right times, that we're not over-testing and doing things that potentially could cause harm. And that's why they have come up with these testing intervals. So this are the current recommendations. And again, they're different. I've been doing this for a long, long time. We used to do pap smears on teenagers. Again, sometimes it's a very unnecessary test. So I'm just going to review with you what the recent, most current recommendations are. Will this be the same thing in 2030? And it may change then. So this is just based on the most current recommendations. So now we don't do a pap smear until women are 21, no matter what, no matter when the onset of intercourse was. Now, if young girls are sexually active, we may be screening them for sexually transmitted diseases, but the pap smear itself, we're not doing until 21. And this is all because of understanding the natural history of what causes abnormal pap smears are related to the HPV virus. Now that information is something that we didn't know about 15, 20 years ago. This is new information. So, and there's a couple, again, things aren't always consistent between various organizations, but between 21 and 29, every 3 years is just doing the pap smear. Now, and I'm going to explain when it says co-testing. Co-testing means we're doing not just a pap smear, but the co-testing part means we're also testing for the HPV virus, because we do know that 99% of the time when you have an abnormal pap smear, it's because of the high-risk HPV virus. And the most amazing thing I think in medicine now is that we're able to vaccinate young women, well, girls between the ages of 13 and 26, to prevent the HPV virus from causing abnormal pap smears. And this is a cancer prevention immunization. This is amazing. And moms ask me about it all the time, and I'm saying, yes, this is proven to be safe, and the risk of abnormal paps and cervical cancer has decreased. We're seeing that now because of that vaccination. So, there's a little pointer here. So when we say co-testing, that means testing at the same time the pap smear itself and HPV virus. So these are the standard recommendations. We'll talk about this a little bit more. Are we actually doing this in practice? Yeah, maybe yes, maybe no. Over 65, and again, this is new, this is a little bit discomforting for women. When I tell my patients, and I see a lot of patients over 65, because I'm a little older myself, when I tell my 67-year-old lady, you know what, your pap smears have been negative forever, and at this point, if everything looks okay, you know what, we don't have to do a pap smear. And they're a little bit anxious again, as somebody trying to take that service away from me. Well, actually, no. It's just that now the risk of doing that, of getting a false positive and doing some invasive tests and causing harm really outweighs the risk of this, unless you have multiple sex partners. And now I'm being exposed to HPV, and they're kind of laugh like, no, they're not having sex parties. So this is why this is like this. And after hysterectomy, and for years and years, when I first trained, we did pap smears all the time on people who had a hysterectomy for benign reason. But that has changed. If you had a hysterectomy for fibroids, let's say, and you no longer have a cervix, and that's what we're doing the pap smear on, you don't have to have a pap smear done. And again, that's a change for people, but this is, and actually this has been for a long time, that you don't need to have that pap smear done. But again, some people have ignored that and done them for a long time, but it doesn't need to be done. So again, this is, again, just to review, cancer is rare in young women, and overtreatment leads to harm. We do know that, for instance, if we do some of these surgical procedures on the cervix of young women, childbearing ages, that can lead to premature delivery and scarring of the cervix. So we don't want to overtreat these young women. And in the past, we thought we were preventing cancer, and now we've kind of walked that back and realized we may really have been doing not such a good thing. Again, but that's, I think in medicine we learn new things as we go along, and things change, and we have to be educating ourselves all the time. Again, cytology alone you could do. So again, we used to test these people all the time for the HPV virus, and we found out, oh my gosh, this is so prevalent in the younger group. Almost every other person was positive for HPV, and people would overreact, oh my gosh. But young, healthy women like this, the vast majority of the time, they clear that HPV virus on their own. And so we don't need to get all kind of over-treat this. We need to just kind of be patient, let people clear this, and they'll be fine. Different, if the HPV persists in this age group, these are the people who are more likely going to have a problem that we want to be vigilant about. Again, I'm going to go through here a little bit more. Again, in this age group, the prevalence of this is very low. Cancer is very rare. Actually, I'm more interested in this age group for vulvar cancer, and more importantly, I want to really do their pelvic exam, feel the size of their uterus and their ovaries to try to detect other kinds of things that could be more prevalent than cervical cancer. So, so here's the key thing, because some people think, oh, if I'm not getting a pap smear, I don't need to come in, right? And I'm like, no, actually, I still want you to come in for your annual GYN exam, or if your primary care doctor does your pelvic exam, that's okay too. It doesn't have to be your gynecologist necessarily, but somebody should be looking at your vulva, looking at your cervix, feeling your uterus, and checking your ovaries to make sure they're not enlarged. Doing the rectal exam, nobody likes that, but that's an important part of that. So that should still be done. It's that pap smear piece that doesn't need to be done once a year. So yeah, we still want to see you, and that's a confusing part, because the assumption is, oh, if you're not doing my pap smear, I don't need to come in, right? And the answer is, no, still want to see you, want to do all those other things, unless your family doctor's doing that, which is okay, and then they'll just send you for specialty care if you need it. But I'm always happy to see you too. Now, but let's say you have HIV. Well, that changes things. Or let's say you had DES exposure, or let's say you had a cervical cancer or dysplasia. Well, that changes the whole thing. Then you may need to have your pap smear done once a year. Well, let's say I did your pap smear and it came back abnormal. Then all that screening interval's off. Those are only for people that have no prior abnormal pap smear. So this is going to change all of that. Let's say you got the Gardasil vaccine. You still should be screened. It doesn't mean now you're off the hook and you still shouldn't have pap smears done at certain intervals. So we can do, now, in terms of this HPV virus, there are low-risk types, which we really don't care about at all, and there are high-risk types. Of the high-risk types, the highest risk types are these 16 and 18, and sometimes we do an extra thing to check for those. So this is just, and so there are, some people check every 3 years, some people want the HPV and the PAP every 5 years. There's some thought that maybe we should just be doing the HPV test every 3 years, because some studies think that the HPV actually is more important than the pap smear itself, and that's what we should be screening for. The jury's out on that. I don't think there's a lot of places that are doing that. So So here's the issue, what are people doing in reality? And I'll confess, okay, so I don't do it every 5 years. There was a couple studies that look like if you do that 5-year interval, you may miss some high-grade lesions. And I'll say that my patients haven't quite got to the acceptance or the comfort level for the 5-year thing. So I'm doing them every 3 years. And there are some physicians and patients who just haven't got to that acceptance level. I have some patients who say, I hear you, Dr. Gutliph, I understand, but I want my pap smear done. Hey, I'm doing their exam, I don't mind doing that, and I will. Insurance tends to cover it. They may not cover the HPV in the pap smear every year, but they tend to cover a pap smear itself every year. Is a pap smear by itself the best screening method? Maybe not. Maybe if they're gonna do it, they should do the HPV. Again, we're still learning things, and everyone needs to feel comfortable with it. But I do think, at least for myself, if you're doing the PAP and the HPV, and everything's been normal, and you don't have high-risk behaviors, at least the 3-year, I think, is very safe. And you could make a case for doing it every 5 years even. Do I think you need to have it every year if you're a low-risk patient? Probably not, if you're otherwise getting good care. And again, this is this isn't reality. So even though we have these guidelines from all these different organizations, sometimes there's a transition time, and it takes a little bit for this to become accepted into practice. And that's a conversation you all need to have with your provider, your gynecologist, your family doctor, so that you can all be on the same page with this. But this is a change, and it is something that, you know, as women, as consumers, that we all need to be aware of and understand why this change is happening. Just like the mammogram intervals that you all hear about too. There's recommendations and changes for that too. In spite of that, it's still a comfort level. It's your body and what you feel comfortable with. And that's it.
Thank you today because it is Women's Heart Month and Heart Awareness Month in general, about the issue of women in palpitations and what we should know in 2017. So thank you to my colleagues at Novant who presented some of the statistical data. And I'm just going to go over some of these statistics because I feel as women and as the population in general, we need to recognize the fact that some of these statistics have not changed over the last couple of decades. So heart disease is still the #1 killer of women over the age of 20. Cardiovascular disease kills approximately 400,000 women a year in the United States. The statistics are reported as 1 in 4 women who die of cardiovascular disease. And more women die of heart disease compared to the next 5 causes of death combined. So you see the red dress, which rises above everything else as far as stroke, lung disease, and cancers. It dwarfs all other types of death in women over the age of 20. So this is why the American Heart Association started a national movement. It's called the Go Red campaign, and it's their effort to really eliminate or diminish heart attack and stroke in women through the power of education and empowerment. So what women often don't know is the fact that as we get older, heart disease rises. The time after menopause is a time where heart disease rises 2 to 3-fold. African American women and Hispanic women may be at even higher risk of death with heart disease. So in order to understand the problem, back in 1997, and now this campaign is 20 years old. So 97, the American Heart Association launched this Go Red for Women campaign, and after 3 years and then 6 years of education, they did follow-up surveys thinking that education is going to help. So unfortunately, 6 years into the educational campaign being launched, cancer was still perceived, despite the scary statistics I just showed you, as the leading problem for women. And still there was under recognition of the fact that certain racial and ethnic groups had a lower awareness, the fact that women's #1 killer is heart disease, And women, despite 6 years of education, still did not know their cardiovascular risk factors. And so the campaign continued. So the campaign is continuing to raise awareness to prevent heart disease and stroke and to save lives. And basically how the strategy is behind this campaign is to educate women and men to know your risk factors, to lead a healthy lifestyle, and to know the warning symptoms of what a heart attack is, what a stroke is. And 20 years into this campaign, I just downloaded the slide a couple of days ago, there has been a huge impact. Despite the fact that the education levels are rising, there's been a 34% reduction in overall death in women with heart disease. So this campaign is having a huge impact on our population because women are taking ownership, they're becoming more aware of their symptoms, of their risk factors, they're trying to minimize their risk, they're trying to educate, empower other women, there's more advocacy, there's more gender-based research, and all of these things have come together to decrease that risk of death in women. But the campaign has to continue. So one of the misperceptions that we have as the general population and providers is that heart disease is considered to be a man's disease. But approximately the same number of women compared to men die of heart disease in the United States yearly. And despite all of our education and awareness, statistics from last year are that just 54% of women recognize that heart disease is the #1 killer. So 46% of women still don't recognize the gravity of this heart disease and how it's impacting us. These are the statistics that the American Heart Association looked at when they kicked off this campaign. So heart disease just kept rising and rising and rising until the 1990s, where about 800,000 people were dying. And the power of education and powerful interventions like lifestyle and diet and exercise have decreased that onslaught of cardiovascular disease. So now I'm going to change gears and talk about my subspecialty, which is what are the symptoms of heart disease in women. So heart disease can present in many different ways. It can present as a heart attack, which is the cessation of blood supply to the heart muscle, and that has classic symptoms such as crushing chest pain, neck pain, jaw pain, sweating, or collapse. Bad forms of a heart attack can actually cause cardiac arrhythmias that can stop the heart. So the most common cardiac arrhythmia is ventricular fibrillation, where blood supply may cease to the heart and the heart just starts to fibrillate and starts to beat at over 250 beats a minute that stops blood supply. So this is a fatal event that can occur as a cause of a heart attack. Palpitations, which is what I end up dealing with a lot of times in clinical practice, can stem from many different arrhythmias, and I'll talk to you a little bit about the common arrhythmias that I see in clinical practice. People who've had a heart attack or people who've been lucky enough to survive a cardiac arrest sometimes go on to have damaged heart muscle that can lead to a lifelong of suffering and heart failure, which is the inability to carry out their activities of daily living because the heart as a pump has been compromised and is not working well. And stroke is another vascular issue that can lead to debility and symptoms and paralysis and a lifelong of suffering. So I'll talk to you about palpitations. So an arrhythmia, which is the manifestation of so palpitation is a manifestation of an arrhythmia, and an arrhythmia is defined as any deviation or a disturbance in normal heart rhythm. Symptoms of an arrhythmia can be mistaken for other conditions such as stress, panic, or anxiety. And women who I see in clinical practice every day are often labeled as having some psychiatric illness such as panic, stress, or anxiety, as opposed to the real thing. And that's the reason that women may not be referred to specialists such as myself at all, or sometimes after years of suffering. So an arrhythmia can lead to a manifestation of a palpitation, and palpitations are defined as a feeling of having a rapid, fluttering, or a pounding heart rate. Palpitations can be triggered by many things. They can be triggered by stress, they can be triggered by exercise, medications, or some medical conditions such as an overactive thyroid. although palpitations, that sensation of it pounding irregular or fast or a strong heartbeat, can be worrisome, most are harmless. If the palpitations continue though, you should go to your primary doctor or even to a cardiologist to try and figure out what it is, because a palpitation may be a symptom of a deeper problem, which is arrhythmic in nature. So palpitations can be divided into 3 different groups. So palpitations that are caused by arrhythmias that have severe consequences, and these consequences can be passing out from an arrhythmia, developing heart failure, having a stroke, or at the extreme dying. They can have moderate severity, such as dizziness or prolonged symptoms that are getting in the way of daily living, or they can be benign, which are easy to ignore, just symptoms of transient shortness of breath, chest pain, or very, very minor palpitations. So these arrhythmias can be felt as skipped beats as well, and approximately 2 million Americans live with the most common cause of palpitations, which is called atrial fibrillation. This is an example of an arrhythmia. More than 800,000 people are hospitalized for heart problems and rhythm problems in the United States, and those numbers are just going up every year. So one of the scary things is in terms of gender, we have different risks of having a cardiac arrest, both out of hospital and in hospital. And you can see from these graphs that men are the most vulnerable to suffer both an out-of-hospital cardiac arrest and an in-hospital cardiac arrest, and you would wonder why. And these researchers published this study in people who have been lucky enough to survive a cardiac arrest. And they saw that men, 80% of people people who'd been resuscitated from cardiac arrest who were men, actually had underlying coronary artery disease. But only 45% of women had coronary artery disease. And that's why men may actually have months-long symptoms of shortness of breath or chest pain or angina type of complaints before their event. Women often don't have any symptoms before, and they have a cardiac arrest because the substrate is so different. So there are very distinct gender differences in the kind of arrhythmias that can happen in men or women. So I had told you that atrial fibrillation is the most common arrhythmia that we see in clinical practice. Another common arrhythmia that we see is SVT, or supraventricular tachycardia. Again, this can be associated with the feeling of a palpitation or a rapid heartbeat, and in women it's often misdiagnosed as anxiety. Interestingly, there's a big hormonal interplay between the occurrence of these arrhythmias and the time in the menstrual cycle. So estrogen that occurs naturally throughout women before the menopause has a powerful antiarrhythmic action, which is similar to calcium channel blockers. When the estrogen level falls right before the menses, that's where we see most arrhythmias occur in menstruating women. There's a distinct hormonal effect. So as an electrophysiologist, we try and schedule elective procedures that are trying to hunt reasons for why people may have palpitations at times when the estrogen level is the lowest, right before the menses. The other common ablation that we perform in both men and women are atrial fibrillation ablation procedures. This is probably the most common arrhythmia that is fixed by electrophysiologists in clinical practice. So basically, this is the left side of the heart. This is a CAT scan image of the pulmonary veins, and this is the area of the heart that atrial fibrillation comes from. It's the wellspring of AFib. And basically how we fix this arrhythmia is by just encircling these veins. So these little dots are where we're going around the veins. These veins are accessed through the femoral vein in the legs, and we look at x-rays and CAT scans to guide us to our target. So this procedure has an equally high success rate, equally low complication rate in men and women, but women are still under-referred by a ratio of 2 to 1 for this arrhythmia. So my group 7 years ago did a study, and we looked at outcome for success rate for atrial fibrillation ablation, and found that although women were under-referred, when they appropriately did come to us, they had the same success rate for treating this arrhythmia compared to men. So just finishing up, I just want to talk to you about 2 other conditions: pregnancies and the feeling of palpitations. Luckily, at the time of pregnancy, palpitations are frequent, but they're most often benign. So this is a Halter study where people were looked at in terms of what symptoms they would have most commonly during pregnancy, and palpitations were number one. But on a Halter, most of the reasons behind the palpitations were benign. So again, I would get a palpitation checked out, but during pregnancy or in menstruating women, it's most likely going to have a benign etiology. In menopause, we talked about the fact that the hormone environment that the body is in really plays a huge part. And when estradiol production goes down, it can lead to high heart rates, palpitations, and cardiovascular complaints. And please don't ignore those symptoms should they start to occur late in life. Similar to atrial fibrillation referral patterns, as a community, we've also looked at what patients are referred for defibrillators, which are life-saving systems. So as a community, we're not doing the best job as far as referring men or women for primary prevention devices. So it's about 55% in men and 51% in women. But statistically, this data is from a year and a half ago. We're referring the same number of men versus women for these life-saving devices. We could do better as a community overall, though. So just to conclude, there are major differences in the occurrence of death, arrhythmia occurrence, response to death, to drugs, and referral for devices, therapy, and trials. Pregnancy and menopause are highly hormonally dependent situations where we can exploit the hormonal environment that is going on in a patient to try and come up with reasons and fix arrhythmias. Trial data remains sparse, and we are doing better as far as gender equality in referring for devices, but maybe not so much in referring for arrhythmia treatment. So I'd like to thank you again for your attention, and it was nice talking to you guys today. Thank you.
Question that I want your participation is, how often is it recommended that we should have our pap smear? But I have to reframe that. Thank you for teaching me something, and ask, how often should we be having our gynecologist look at our vulva? Is that the right question? So how often is that? Once a year, right? Okay. So my question to you is, how often is it recommended that we should have our physical checkup? You're right. How often is it recommended that we should visit the dentist to have our teeth checked and cleaned? Oh, you're so brilliant. I love it. At what age, this is for my speaker that's after me, I may be wrong, but at what age is it generally recommended that we should have our first mammogram? 40. All right, I was right. How often is it recommended that those of us that have sensitive skin should see our dermatologist to have our moles and freckles and everything checked? Once a year, annually, okay. Here's a trick question for you. How often is it recommended that we should have our hair trimmed? Who said 6 weeks? 6 weeks. She knows her hairdresser. Okay. So here's my question to you. How often is it recommended that we should have our emotional and mental health checked? Wherever that is, just go. Okay. So, but is there a guideline? No. There isn't a guideline. So, with that being said, I want you to know, and this is absolutely true, in preparing for this talk today, I was actually just your vision. Welcome to my new glasses. You schedule, I scheduled my dental appointment, and as I was thinking, what am I going to talk about to all these professional, educated women? Do they want to hear about stress? No. Everyone can Google that. Do they want to hear about this? Suddenly struck me that there is not an annual, semi-annual appointment for our emotional and mental health check-in. There isn't. So it was really profound for me. And with that being said, I have spoken to many of my colleagues, both local and California, asking, hey, what do you think about this? Have you ever thought about it? And with that being said, it was an aha moment. Don't you think it's paradoxical that we take care of from down here? we're hardwired. We're almost programmed to, which is why we have a difficult time of understanding we don't need to have a pap smear once a year necessarily, depending on our condition. But my question is, why is there a distinct difference in separation of our mental health and emotional health from our physical health? Isn't the brain considered the hub or the hard drive in our body whose primary function is for transmitting and communicating billions of our thoughts, feelings, automatic actions like breathing, reactions and behaviors? Isn't it an important muscle and organ? Isn't it one of the most important muscles and organs? I continue to ask my questions of how did mental and emotional health get missed on this so-called medical wellness checklist? What's the underlying message being sent to the community, society, to women, that all of the other areas of our body are important or a greater priority than our own mental and emotional health and wellness? Or did someone a long time ago in a sign-filled moment just have a clerical error and forget to add emotional mental health to this hardwiring checklist of our healthcare institutions and providers to just fall off the list? Or is it that we really don't need some kind of a checkup or check-in for our mental and emotional health? Good questions. So I'd like to review some data with you in researching this, and just to give some context. So once a young woman starts menstruating, she begins to experience emotional changes around the time of her period. 75% of women with regular period cycles report unpleasant physical or psychological symptoms before their periods. Premenstrual syndrome, we now know PMS, affects anywhere between 50 to 80% of women. The psychological symptoms of PMS include depression, anger, irritability, anxiety, sensitivity to rejection, sense of feeling overwhelmed, and social withdrawal. Research also shows that women who experience stress tend to use alcohol as a coping skill. Women that experience stress and have trouble in their closest relationships tend to drink alcohol more than other women. An estimated 5.3 million women in the United States drink in a way that affects their health, their safety, their general well-being. Women don't deliberately go out and make a conscious decision to hurt themselves and hurt their health. A strong case can be made that heavy drinking is more risky for women than men. Heavy drinking increases a woman's risk of becoming a victim of violence and sexual assault. The health effects of alcohol abuse or alcohol misuse, one of the new terms, are very serious. Some of these health-specific problems are alcohol liver disease. Women are more likely than men to develop alcohol hepatitis and to die from cirrhosis. Brain disease. Most functioning alcoholics have a loss of mental function, a reduction of their brain size, and changes in overall function of brain cells. Research suggests that women are more vulnerable than men to alcohol-induced brain damage. Cancer. Many studies report that heavy drinking also increases the risk of breast cancer. And heart disease, which we've just heard, that chronic heavy drinking is a leading cause of cardiovascular disease. And among heavy drinkers, women are more susceptible to alcohol-related heart disease, even though women drink less than men over a lifetime. A university in Wales found that if a person was mentally rested before a big day of physical exercise, that they lasted longer on the day of their physical exercises and felt better compared to a person that was mentally and emotionally fatigued the day before the physical exercise. We know that uncontrolled anger is a direct indicator to high blood pressure and heart problems. Men and women coping with anger and aggravation are 10 times at an increased risk for heart arrhythmias than those without anger problems. Professor Goldberg from the Institute of Psychiatry in London reported that the rates of depression in chronic illness is almost 3 times higher than normal. And he stated that although depression and chronic illness is in a reciprocal relationship with each other, depression amongst those with a chronic medical condition is often missed by their physicians and provider team due to these health professionals who are generally caring for the sick patients, and it's often going untreated. And it's not like we're the biggest advocates for ourselves sometime in this area.
I'm always sitting there deep breathing for 10 or 15 minutes. I don't want to talk to anybody. So, anyway, my name is Dr. Tammy Lamb. I work at the Medical Center, and I'm a diagnostic radiologist. My specialty is intervention and diagnosis of breast cancer. So, I'm going to give you a quick update on the diagnosis of breast cancer. I'm always surprised that I have to give this sort of update every year because unlike OBGYN and pap smear related issues, or even whether it's for cardiovascular, the actual guidelines from the science base, it has not changed. From the imaging community, we still say the same thing. So, why is it constantly that I have to give this talk? And I believe it's because it's been in the news and out in the forefront so often. And it started mainly in 2009 when you came out with the United States Preventive Task Force recommendations that we should go from every year mammography to every 2 years, change from age 40 to age 50. All of a sudden, women who have been told since the 1970s, 1980s, that mammography saves lives, they're now being told you don't really need it. You also have things such as density laws, where some women will, write a long op-ed saying, my mammogram did not find my cancer. And that's not the common response you get. It's not what you had, the common outcome, but it is an outcome for a small section, a small percentage of women in this country. But the reality is, for the majority, the actual recommendations have not changed. So the questions I keep on getting, every year, women will work, do I have to get a mammogram, yes or no? My own mother, who is happy I'm a physician, says every time, why do I have to go get a mammogram? And I'm just like, because I love you, okay? If I get one, do I start at age 40 or age 50? Because as you said, it has changed. Do I need it after age 70? Do I stop, or do I continue as long as I know I'm living another 10, 15 years and I'm healthy? Do I get it once a year or every 2 years? And what are the actual harms of imaging? Everyone keeps on telling me there's so much harms to imaging and having my mammogram. And they want to know, is it worth the risk? The breast density laws, and of course, people worry about the cost and insurance of it, because preventive health care for women tends to be a little bit expensive, and we're asking you to start something early on, age 40s for most women, when they're taking care of their family and everything else. So, I think it's in the news so much because breast cancer in this country is a very big deal. It used to not be the #1 diagnosed cancer in women, but with the advent of like the smoking ads telling people that cigarettes is associated with lung cancer, etc., it has come to surpass other cancer diagnoses to being one of the in most stats saying it's the #1 diagnosed cancer in the United States. So basically the NIH, which is involved with evaluating statistics of cancers within the United States, states that in the United States specifically, not around the world, that there are probably over 3 million women that are living with the diagnosis of breast cancer. Wow. Whether they've been cured or not, but it's basically living with that. The lifetime risk for breast cancer in women has not changed. It's still 1 in 8. And this is based on the last set of numbers that they study. They study them like every 4 to 5 years. And so it's the last set of data that came out in 2013. It was estimated in 2016 that almost 250 million women will be diagnosed with invasive breast cancer. That's cancer that has to be treated a lot of times with much more aggressive therapy than just surgery or a pill. But there's also another 60,000 that would be diagnosed with early stage breast cancer or ductal carcinoma in situ or in situ carcinoma. Breast cancer itself represents 14 to 15% of all cancers diagnosed in women. So you're talking about everything: colon cancer, lung cancer, skin cancer, vulva cancer, all of them are involved. So this is it, but it's 15% for one diagnosis. And of that, even though I gave you all these bad stats now, it only represents about 7% of cancer death, but that's still a lot. 40,000 women a year will die of their disease. So when we look at this, the reason that I want to answer that first question of do we start at age 40 or age 50, you got to look at the distribution of breast cancer. I hate to say it, I feel like I'm seeing it earlier and earlier, and I worked at Yale when they were working on people with the BRCA gene. When I saw people that were coming early, I still feel like I'm seeing it earlier and earlier. The majority of women are diagnosed from age 45 to 75. So yes, starting at age 50, you may have already had that risk for 5 years of a mass developing. But you're seeing almost 10% of women having diagnosed with cancer between age 35 and 44. I even see several women under age 35. Now, how about the more mature women? 15% are diagnosed after 75. And women are living longer, we're living healthier lives, and the last thing you want to do is live the last couple of years fighting a cancer. The mortality rate associated with breast cancer, the median age is higher. Women in their 40s and 50s, although they're diagnosed early, we are seeing that the median age of mortality really is in their 68, not later in life. And so the majority of women that pass away of disease, basically from age 55 to 84. The incidence of breast cancer among populations are somewhat similar between Afro-American women and Caucasian women, but yet the mortality rate we do see, as we see in most different diseases, are slightly higher in different groups. In this case, the mortality rate is higher in Afro-American, and it may be a socioeconomic association. What they say is that the 5-year survival rate in Black women is like only 78%, whereas in Caucasian women it's 90%. And now that I give you all that terrible stats, and I've depressed everyone after a very funny talk, I like that. I just wanted to give some good news though. Yes, we have increased the diagnosis of breast cancer since we started doing mammography in the 1970s, and after we started doing the regular screen mammography in the 1980s. The diagnosis has gone up. It's somewhat leveled off. The nice part though is that the death rate has slowly decreased, almost 1 to 2% every year. So we must be doing something right. This is just to give you a close-up view, saying from 1992, it's been a steady decline in the death rate. And we believe in the science community that that has to do with mammography. Okay? So, when I answer that question, do you need to get a mammogram? Yes, you do. What age do you need to get a mammogram? Since the distribution is, starting at age 45, I say at age 40 because you find something early, the treatment is less invasive. The next question is, women ask me, well, I don't like mammography, there's harms, I don't like my breast being squeezed, it hurts too much. I got that the very first day in my residency, and I swear to God, I went right into the mammogram room and I asked the tech to squeeze me. I said, I gotta see what this feels like, because this is supposed to be the worst thing in their life. And I was like, are you kidding me? These people have had, I gotta believe that wearing shoes too small and having a baby has got to be more painful. Because it hurts for a second. It does. I'm not saying it's not painful, but if you're telling me you can save my life, I have extremely high family risk. And if you're telling me that, a woman comes and you know that you have a 50% chance of breast cancer, you don't want to do 8 seconds of being a little uncomfortable? We wear high heels, and you said it, that we can't walk in. And we will stand at a party for hours, but we don't want to get a mammogram and get it done. That's why I think, so now what we're looking at are, what are the different tools? So women will say to me, I don't want a mammogram, I want an ultrasound. I heard that ultrasound's better. Ultrasound actually finds more cancers. It didn't find this other woman's cancer. Oh, I want MRI. I hear it's better for people that, that find cancers really, really early. Some people want nuclear medicine, and there's newer techniques coming out, mammography. I don't want to discuss all of them, but what I want to say is that the gold standard still is mammography. It is the one modality we have that at its price point and its ability to deliver it to a large population gives us the best outcome. And the reason is it finds all 4 ways that cancers present. So we all hear that cancers come as calcifications, we all hear that cancers come as masses. But you may also may not have heard that cancers appear as architectural distortion, and it sounds exactly what it looks like. It's distorted lines being pulled, or it comes up as asymmetry, and that has to do with the density of our breasts. Breast is made up of fibroglandular tissue and fatty tissue, and how that is distributed is usually supposed to be mirror images of each other. But if you have a little bit more asymmetry in one area, that can be a sign of cancer. All 4 of these are seen by mammography, whereas ultrasound, it shows masses, and if you have a very good technologist and radiologist, it can show architectural distortion and maybe calcifications early. MRI, it's very good for masses. It may show asymmetry, it may show calcifications, but it has a high negative false rate for both asymmetry, calcification, architectural distortion. So when you look at across the board, of the 4 modalities, mammography is still the gold standard, whereas everything is an adjunct to it. So when I have a woman coming in insisting she doesn't want a mammogram, I'll do that ultrasound just so I can spend 30 minutes convincing her she should get a mammogram. Because to me, she's walking out of there thinking, I did the best I could for myself and I'm fine. And that's not true. So, how do we find this out? It was all through studies. Basically, mammography was studied worldwide, not just in the United States. and we looked at how it affected the diagnosis and the mortality rate of breast cancer. So in 1980s was the most significant increase in diagnosis. This was after we started implementing a more countrywide screening study. More women were actually involved. In the 1990s, we started seeing a steady decline, right? So we started doing mammography regularly on a regular basis, and all of a sudden, less women were dying of their breast cancer. The common denominator was 1950, okay? When we look at all the studies across the board, we believe that there's a decrease of approximately 30% in the mortality rate, and people say that's conservative. Because if you think about it, what you're looking at in a study are women that are always able to do what they're supposed to do, and we know that's impossible. How many women forget to get their mammogram? How many women just simply are taking care of their family and 2 or 3 years may do it? How many women just aren't compliant because they can't be? Or if they don't have the financial means for it, just to have the studies done, or the availability where they live. So this is a conservative estimate that's based on the best practice, that women are always able to get their annual mammogram. What we find now also is that when we looked at